Now, depending on the depth of sublabral recess, we can have different types. Okay, so type 1 is basically actually no recess. It's the labrum is firmly attached to the articular cartilage, so we do not have any recess. So this is a normal type 1. So type 2, you can see a fluid segment density which is undercutting the, or you can say which is cutting the undersurface of the. So this is your basipetalabral complex on the superior side. So you can see a fluid segment density which is going along the orientation of glenoid, less than 2 mm, uniform, smooth margins. Right? So this is basically a sublabral recess. Okay, it's a normal variant, no arthroscopy required. In this, you see much more thicker. This is the normal orientation of glenoid. It's going opposite to the orientation of glenoid. Okay, does not have, it's non-uniform. Okay? You'll see it's broader at the base and narrower at the near the labrum. Okay, has non-smooth margins. It's more than 2 to 3 mm in width. Okay, and may extend posteriorly to involve the biceps anchor also. Okay, so this is a definite slap tear. Okay, so the biceps anchor is just since I told you that the attachment can be varied, okay, depending on the section. So that is why I told you that labral attachments of the biceps anchor can be varied. We can have predominantly posterior superior, with then we can have a small anterior superior component, midline also, and along with that predominantly anterior superior. Out of that, the posterior superior attachment is the most common. So sometimes what may happen is, so in a section which you're taking in the corner of big section, the biceps anchor may not be visible in that section because the attachment of that biceps anchor is predominantly on the posterior superior margin or the posterior superior limb. Okay. The main concept here behind the sublabral recess is that if the biceps anchors get involved, it is never a sublabral recess. Okay. So not all slap tears also, they do not involve the biceps anchor. Okay. So if there is biceps anchor involvement, okay, no matter whether it's uniform, smooth, or it's less than 2 mm, more than 2 mm, it is a definite slap tear. Okay, sublabral recess cannot extend towards the biceps anchor and involve it. So please remember that. Okay, so that in all the cases of sublabral recess, you will see that the biceps anchor will be normally attached with no tear of the biceps anchor. Okay, so there are 2 points now. Okay, so biceps anchor, one is the attachment point and other one is the tear extension. So the attachment, it can be bony also, it can be labral also. Now there are certain slap tears in which we have detachment of the bicipito-labral complex. Okay. So if it's a sublabral, and there are some slap tears also in which a tear of the superior labrum extends like a slap 4 tear, it extends into the biceps anchor region, not at its attachment site, but just near to the attachment site. I'll explain. So suppose this part as a whole, this is your glenoid, it starts getting detached from here. Okay, so this is the detachment of the biceps anchor or the uh, biceps anchor labral complex. Okay. Second is we can have a tear of the superior labrum which is going like this, which may extend into the biceps anchor. So biceps anchor can be involved either at the attachment site or just adjacent to the attachment site with extension of the tear from the superior labrum. Okay. Now, if it's a sublabral recess, both the attachment site as well as the part of the biceps anchor just adjacent to the attachment site will be normal. Okay, so attachment will also be normal. There will be no extension of any you can say hyper intense signal density into the part of the biceps anchor just adjacent to the attachment. Okay, so that will also be normal. Okay. If any of these are involved, okay, no matter rest of the features, it will definitely be a slap tear. Okay, so For it to be labeled as a sublabral recess, the attachment of the biceps anchor and the part of the biceps anchor just adjacent to the its attachment, both should be normal. Okay. Then there are other points also that it is extending along the orientation of glenoid, uniform, smooth margins, less than 2 mm width. These are all additional points. Okay, I hope it's clear. Okay. Now, I told you that we can have different types of sublabral recess. So, type 1 is actually a no sublabral recess. That is a firm attachment between the cartilage and the superior labrum. Okay, so there is no basically cutting of the undersurface of the superior labrum by the fluid signal density. Then the rest of these are basically depending on the depths. Okay, if it's zero, it between 0 to 2 mm. Okay, the rest of the features are almost same. Okay, so that is your type 2. This was given by Smith. If the depth is almost 3 to 5 mm, okay, the orientation and the uniformity, the smooth margins, the rest of the features will remain the same. Just the depth is changing. Okay, so the type 3 is about 3 to 5 mm depth. Okay, this is about 3 to 5 mm. Okay, then before moving on to the type 4, there's a thing we call it as a meniscoid labrum. Okay, so you know about the menisci in the knee. Okay, so they are like this. Okay, so they basically, what do the menisci do? They basically project into the joint space. So sometimes we can have the labrum which is projecting into the joint space, or we can say it's an overhanging labrum. The term we call it as meniscoid. Why? Meniscus looking labrum. Okay. Uh, for our concern, it's usually mostly seen in the anterior superior labrum only. Okay. Okay. It's basically a curved redundant overhanging labrum. It's like a meniscus. I'll show you the images also. Okay. So it's the the sublabral recesses, the depth is so much that the superior labrum basically hangs in the glenohumeral joint space as you can say a triangular meniscus. Okay, so this is a meniscoid labrum. Okay, because so much part of it has is basically there's a space between the labrum and the glenoid articular cartilage. So the space is so much that it is almost hanging like a menisci, a triangular hypodensity into the glenohumeral joint space. Okay. Now, since the depth will be more than 5 mm, okay, so this is your type 4 type of sublabral recess, which is most importantly associated with a meniscoid type of labrum. Okay. Okay, so it's often associated with a deeper sublabral recess, smooth triangular overhang. Okay. The rest, all the features of recess will remain the same. Uniform, less than 2 mm, smooth margins, that will all remain the same. The orientation also. Okay. So it can, I've seen most of the people who are labeling these as slap tears, but this is actually not a slap tear. Okay. So this is a meniscoid labrum. Okay. Just see the orientation, just see the smoothness of margins, just see the uniformity. Okay. So this is actually nothing but a type 4 sublabral recess. Yes, they're more predisposed, you can say that. So it's a type 4 sublabral recess. Okay, so please do keep this in your mind. Okay, so check all the features and then only proceed with your diagnosis. Okay, the other name for this is obviously your pseudo slap tear. Okay, but it's actually not a slap tear. So the better term to be used is your type 4 sublabral recess with a associated meniscoid labrum and the depth of the sublabral recess more than 5 mm. Okay, this is just a table. Okay, which I made. You can, so I've told you about all the features. Okay. Just main thing to remember is the type 4 sublabral recess will not cause any instability to the uh, shoulder joint. So even in asymptomatic patients, you can have this finding. Okay. While slap tears, uh, they are usually pathological. They may cause micro instability. Okay. We are talking about the types after 4, like 5, 6, 7, 8, 9, 10. Okay. Moving on to the second important variant, which is your sublabral foramen. Okay. We also call it as a sublabral hole. Okay. So what is a hole? It's nothing but basically the part of the anterior superior labrum from 1 to 3 o'clock position is not attached to the glenoid cavity. Okay. Okay, so it is located anterior, okay, since it's from 1 to 3 o'clock position. So it is located anterior to the bicipitolabral complex, and it basically represents the space between the anterior superior labrum and the adjacent glenoid cartilage. Okay, so it's very well seen on your axial images. Okay, these can be seen in continuity with the sublabral recess also. They can may occur independently also. Okay, so very simple. So definition for this: not non-attachment of the anterior superior labrum to the bony glenoid from 1 to 3 o'clock position, which rejoins the normal labrum at 3 o'clock position.